Welcome everyone again to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This series is run by the Division of Forensic Behavioral Sciences of the University of New Mexico's Department of Psychiatry and Behavioral Sciences in support with the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenter, make sure you enter them in the Q&A box. You can enter those anytime you feel comfortable, but do know that we hold questions until the end, and oftentimes it's not possible for us to get to all of them. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box shortly. Similarly, if you are pursuing APA continuing education credits, the link for the survey that you'll complete for your credits will be posted in the chat box, but that link will be posted near the end of the presentation. So keep your eye on the chat box near the top of the hour as we get ready to close. Make sure that you bookmark or open that link before the webinar closes, and also make sure that you save a copy of your certificate afterwards. We do not have access to PDF copies of the certificates after the fact. If you missed last week's talk in the series, Dr. Robert Beatty's thorough discussion of the business of forensic psychology is now available on our YouTube channel. The recording for this week's talk should also be available on our YouTube channel sometime later this week, and PowerPoint slides for those that have registered for the series will be available later this week as well. As a heads up, next week we have Dr. Emmy Wood, who will be discussing unique considerations for competency evaluations for those with intellectual disabilities. But circling back to this week, I am professionally and personally excited to introduce you to today's speaker, who will be discussing maternal filicide, including maternal mental illness, mitigation, and criminal responsibility issues. This is Dr. Megan Shedd. Dr. Megan Shedd is a forensic psychiatrist and reproductive psychiatry fellow here at the University of New Mexico in our Department of Psychiatry and Behavioral Sciences. Her clinical focus is in perinatal and women's mental health, and she has prior experience as an attending psychiatrist on the Inpatient Services at the University of New Mexico Psychiatric Center. Dr. Shedd earned her medical degree from Baylor College of Medicine, where she received grants from the Texas Medical Association and the American Psychiatric Association to coordinate outreach programs for resettled refugees and asylum seekers. She also holds a master's degree in public health, focusing on maternal and child health from the University of Texas Health Science Center. She completed her psychiatry residency here at the University of New Mexico School of Medicine and her Forensic Psychiatry Fellowship at Case Western Reserve University. During her training, she was chief resident in Rural and Community Psychiatry, has received research awards, and was awarded the APA SAMHSA Minority Fellowship. She also served on the APA Council for Psychiatry and the Law and the Committee on Judicial Action as a fellow member. Dr. Shedd's an active member of the APA and the American Academy of Psychiatry and the Law, serving on AAPL's Committee of Gender Issues. She has presented at regional and national conferences and has published works on topics including maternal mental health, psychiatric malpractice, and postpartum psychosis. Her academic interests encompass the intersection of women's mental health and the law. We've definitely been excited to have her join us as a forensic psychiatry professional here in the University of New Mexico. So Dr. Shedd, Megan, on behalf of the University of New Mexico, thank you so much again for joining the series. I'm very excited to have you joining and sharing your expertise with us today. I'll go ahead and toss it over to you.
Thank you so much, Anthony. So today I want to talk about something that I'm really fascinated by. It's a difficult topic, of course, so I hope I give it the respect that it deserves. It's Motherhood, Mental Illness, and Murder, Demystifying Maternal Filicide for the Forensic Mental Health Professional. So I just want to say that the views expressed in this presentation are my own, and I don't have any financial conflicts to disclose. So we're going to dig into this very important topic, maternal filicide. Not just what happens, but why it happens and how mental illness plays a role, and what we need to think about as forensic mental health professionals. So to help guide us, there are some things that I want to impart on you. I hope that you take away these points from this talk. So by the end of the talk, I hope that you can describe the epidemiology, clinical factors, and common motives associated with maternal filicide, discuss infanticide laws and safe haven laws in the US and internationally, and analyze the phenomenon of child maltreatment, peripartum psychosis, and pregnancy denial for forensic evaluations and testimony. And before we jump into the main content, I really want to clarify a few terms that I'll be using throughout this talk. When I say child homicide, I'm referring to the killing of a minor by anyone, not necessarily a parent. Filicide is more specific. That's when the person is responsible is the parent or parental figure. We often break this down further into maternal and paternal filicide, depending on whether the mother or the father is involved. And there are two subtypes of filicide: infanticide, which means the killing of a child under the age of 1 year, and neonaticide, which refers to the newborn killed within the first 24 hours of life. And these aren't just clinical distinctions, they often point to very different underlying dynamics. For instance, infanticide is more commonly linked to peripartum mental illness, while neonaticide tends to be associated with pregnancy denial. And we'll dig deeper into these patterns as we go along. So let's talk a moment about how maternal filicide is portrayed in the media, because these things not only get a lot of attention, but they often reflect public misunderstandings about maternal mental illness. And those same misconceptions can show up in courtrooms, which shape outcomes. So take the case of Lindsay Clancy. This is a Boston nurse and mother who was charged with killing her 3 young children before attempting suicide. Her defense team and her husband say that she was in the grip of postpartum psychosis. Of course, prosecutors disagreed. They argued that planning was involved. Things like sending her husband out of the house and timing his return proved that it was premeditated. And this case demonstrates a common misconception that the belief that if someone planned an act, they could not have been psychotic. And as you know, in reality, people with psychosis often do appear organized and goal-directed, even while their thinking is impaired. Another example comes from the UK. This is the case of Paris Mayo. She was just 15 when she gave birth alone in her parents' living room while they were sleeping. She said that she didn't realize she was pregnant until right before she went into labor, and that the baby died during delivery. Prosecutors claim that she had knowingly hidden the pregnancy and had actually intended to kill the baby. And the jury found her guilty, and now she's serving a 12-year sentence. And so this case reflects another widespread misunderstanding in the public and in courts that it's impossible for someone to be unaware that they're pregnant. So these cases and many like them really highlight why our role as mental health professionals matter in the courts. So we can help the courts understand the psychological realities behind these events and push back on oversimplified and stigmatized narratives. So I want to start by looking at some seminal research in filicide, specifically 2 foundational papers by Dr. Resnick, who was one of my mentors at Case Western, which was published in 1969 and 1970. So Resnick conducted a review of global literature spanning over 2 centuries from 1751 to 1967. He analyzed 131 cases of filicide and 37 cases of neonaticide. And one of his key contributions was recognizing neonaticide as a distinct phenomenon with its own clinical and psychological underpinnings. He also proposed 5 filicidal typologies based on motive, which remain clinically and forensically useful today when we're approaching these cases. So let's take a closer look. The categories are altruistic filicide, acutely psychotic, perhaps better described as no apparent motive or no comprehensible motive, unwanted child, accidental, also referred to fatal maltreatment, and spousal revenge. So in altruistic filicide, the parent believes that they are acting in the child's best interest, that the killing is for a greater good. And there are 2 subtypes. There's filicide associated with parental suicide. So this In this example, the parent feels unable to leave the child behind and believes that the death of the child will spare them from abandonment. And then there's filicide to relieve suffering, where the parent believes the child is suffering or will suffer due to real or imagined illness or some external threat. This type of filicide is commonly associated with peripartum mood and psychotic disorders among mothers, with mothers being the most common perpetrators. Acutely psychotic filicides occur during episodes of psychosis or delirium. They're typically carried out without any apparent motive. Parents act, in a state of extreme disorganization. And Resnick also described rare cases involving epileptic automatisms where the killing occurred during a state of post-ictal confusion. And in these instances, the parents had no memory of the act. Unwanted child filicides refer to cases where the child is perceived as a burden or obstacle. These killings often occur in the context of unplanned pregnancies, doubts about paternity and financial stress, or social stigma, including outdated notions of, the child being illegitimate. Fathers were the more likely perpetrator, and in some cases, the child was seen as a barrier to personal freedom, new relationships, or career advancement. Accidental filicide refers to the death, the child death that results from physical abuse or excessively harsh discipline without a specific intent to kill. And so that's why the term accidental comes up, because, not because it was a harmless act, but the perpetrator did not have homicidal intent and often asserted that it was an accident. In these cases, the fathers are more frequently the perpetrator. Spousal revenge filicides occur when a parent kills a child to inflict emotional pain on their partner. These cases often involve a backdrop of marital conflict, infidelity, or separation. In this context, the child may be seen not as an individual, but as an extension or possession of the other parent. So mothers were more frequently the perpetrators of filicide than fathers, and mothers were more likely to have mental illness. So 67% had psychosis and 71% had depression. Mothers tended to kill younger children, especially infants under 6 months, which is a period, associated with postpartum mental illness. Fathers were more likely to kill older children, often those that they perceived were disobedient or unwanted. Mothers were more likely to be psychiatrically hospitalized, whereas fathers were more likely to be incarcerated. And even methods varied by gender. Mothers were more often using drowning or suffocation, whereas fathers were more likely to use blunt force trauma or a penetrating weapon. So Resnick coined the term neonaticide and recognized it as a unique phenomenon distinct from infanticide. So how are these things distinct? So neonaticide occurs in the first 24 hours of life and is often preceded by pregnancy denial, whereas infanticide occurs in the first year of life, usually within the first 6 months of life, and it's associated with postpartum mental illness such as depression, psychosis, and suicide. With respect to motives, Resnick asserted that 83% of neonaticides stemmed from the newborn being perceived as unwanted, and the motive in infanticide is typically altruistic or acutely psychotic. And then neonaticides tend to occur by or committed by young unmarried women under the age of 25, whereas infanticide perpetrators were often older and married. The next study was conducted by a forensic pathologist, Wilkie and colleagues, and they looked at 49 cases of child homicide over a 10-year period in Australia. And based on their review, they identified 7 different patterns of child killing. And their findings were largely in line with what Resnick had described earlier. So their typologies were non-accidental injury and deprivation or starvation. So these closely align with what Resnick described as that accidental filicide or fatal maltreatment. Wilkie described neonaticide and found that it was also associated with pregnancy denial or concealment. Wilkie also added an additional category of murder, some of them including sexual assault, and these were intentional killings. Then the category of murder-suicide, which also tended to fall into an altruistic category. They identified infanticide and associated it with mothers with postpartum mental illness. And then there was the euthanasia, which were rare cases of mercy killings involving children with either severe illness or disability, which also fell in line with the altruistic filicide category. So you can see that there is significant overlap here, even though we're looking at different cohorts. The other thing that's important to recognize is that Wilkie's results align with current frequencies of filicide. So fatal maltreatment is now the most common. Infanticide has declined really with better psychiatric care. It's relatively rare, whereas neonaticide falls somewhere in the middle. So now that we've covered the foundational research and typologies, I want to shift into looking at 3 key filicidal subtypes. So we're going to start briefly with fatal maltreatment and then dive more deeply into infanticide and neonaticide. And I want to start with maltreatment because it's the most common type of filicide, and it's easy one to overlook in these cases when you're focused on rare, high-profile presentations. And so that's important because I've seen instances where the defendant is seeking a mental state defense, based on postpartum mental illness, but the facts aligned more closely with abuse or neglect. And so it's critical to keep fatal maltreatment on the radar really in any filicide case. So we're going to start by looking at its prevalence and then the characteristics of the parents that are involved. So we have some recent data from JAMA Pediatrics looking at about 38,000 child homicides in the US between 1999 and 2020. And it showed that homicides of children 10 years or younger were most commonly precipitated by abuse and neglect, and the perpetrators were most commonly parents. And so that really reinforces what I've been saying, that fatal maltreatment is the most common form of filicide. Another thing that was important were that the different methods. So the most common methods were blunt force trauma, strangulation, and drowning. And so the data also from CPS reflects this same reality that that this is common and that it's a major burden in the US. So every year there are 4.3 million referrals to CPS with over 550,000 substantiated cases of abuse and neglect, with around 2,000 child fatalities per year. The youngest children are most at risk, with infants under the age of 1 having the highest rates of victimization. And several parental risk factors increase the likelihood of child maltreatment, especially fatal abuse. So stress and frustration, including poor impulse control, mental health conditions such as PTSD, maternal depression, and borderline personality disorder, the parent having a personal history of being abused in their childhood, substance use disorders, single parenthood and young parental age, low educational attainment, domestic violence in the home, criminal history, use of excessive punishment or corporal punishment, perceived difficulty managing the child, especially during challenging stages like, early in the infant's life when they're crying and they're often inconsolable, or during toilet training. And so these risk factors really help explain why very young children who are more dependent, more difficult to soothe, are especially vulnerable. And when we think about child maltreatment from the lens of maternal mental health, it's really important to recognize that most of these cases don't stem directly from postpartum mental illness, such as postpartum psychosis. More often, they arise in the context of chronic stress, impaired parenting capacity, poor frustration tolerance, and the use of harsh discipline. That being said, factors like PTSD or history of trauma, if they are present, may be relevant as mitigating circumstances. Now I want to shift our focus to look deeply at infanticide. These cases are less common, but they tend to draw a lot of public and legal attention. And unlike fatal maltreatment, infanticide is more likely to involve acute mental state disturbances like postpartum psychosis. And these are the cases where mental state defenses may be applicable. And so we're often brought in to help determine if that's the case. So we'll look at clinical features of infanticide and patterns that we tend to see in the mothers who commit these acts. To start, I want to look at a well-known case, Andrea Yates. So in 2001, Yates drowned her 5 children in a bathtub. She was 6 months postpartum at the time and experiencing severe untreated psychosis. She believed that she was a bad mother and that killing her children would save them from eternal damnation. And so this was a clear example of altruistic filicide. And her case is one of the most well-known examples of infanticide tied to postpartum mental illness. And it significantly shifted public awareness, but not without ongoing misunderstanding and controversy. So we often use the term postpartum psychosis broadly. You'll see it kind of described in the literature, and I even use it broadly, but the term can be misleading. So psychosis in the postpartum can stem from several well-known mental disorders. You can have major depression with psychotic features, which typically has a gradual onset with depression preceding the psychosis. You can have schizophrenia, where you might have chronic psychosis during pregnancy that extends into the postpartum, or you have bipolar 1 disorder with prominent mania and maybe a secondary psychosis. But the syndrome of postpartum psychosis appears to be a distinct clinical entity, one that typically emerges abruptly and often in women with no prior history. And it follows a unique course. So I've seen patients with a single severe psychotic episode in the postpartum with no symptoms before, and they haven't developed symptoms after. Others have had this kind of cyclical psychotic episodes that occur only related to childbirth. And so these presentations of postpartum psychosis don't always fit neatly into existing DSM-5 categories, which means it takes some extra care from us as mental health professionals to explain this to the court when we don't have the DSM-5 criteria to rely on. So how is postpartum psychosis distinct? Well, there are a few key features to keep in mind, especially when you're evaluating maternal filicide. So it typically has a very abrupt onset, usually within the first 2 to 4 weeks postpartum. The presentation can look almost like delirium with waxing, waning confusion. So a mother might appear lucid and organized one moment, then disoriented or incoherent the next. This kind of fluctuating mental state is especially important when we're evaluating for criminal responsibility, because it can complicate assessments of intent and awareness of wrongdoing. So for example, a defendant might have a seemingly coherent, account that she gives to police, but hours earlier was found incoherent and disoriented by her family members. In postpartum psychosis, we often see significant mood lability, rapid shifts between agitation, tearfulness, and flat affect. Delusions frequently center on the infant, such as the belief that the baby is evil or in danger or needs to be saved. Postpartum psychosis is strongly associated with bipolar disorder. Many women go on later to have manic episodes and receive a diagnosis of a bipolar disorder. Oftentimes, there's a history of hypomania or mania in the past that went undetected. But that being said, up to 50% of women who experience postpartum psychosis have no prior psychiatric history. And so that's an important consideration in forensic evaluations and testimony, because oftentimes juries may be skeptical of an insanity defense when there's no documented history of mental illness. And it reinforces the need for clear and careful expert explanation to help courts understand that this can present, distinct and acute, and in some people with no prior history. So now I want to look at some literature that helps us understand the differences between infanticidal mothers with and without psychosis. So Lewis and Bunce conducted a retrospective chart review of 55 mothers who committed filicide, and they were referred for criminal responsibility or competency evaluations. And so what did they find? Mothers with psychosis who committed infanticide were more likely to be older, be divorced or separated, have higher education but be unemployed, have a history of psychiatric hospitalization, outpatient treatment, and substance abuse. Clinically, they were more likely to have a diagnosis of schizophrenia or major depression with psychotic features. They were likely to have command hallucinations, paranoid delusions, and histories of suicide attempts before the filicide. Mothers with psychosis often voiced concerns about their children to family or clinicians shortly before the act. They tended to confess immediately afterward, and they often believed they were saving their children. In contrast, mothers without psychosis who commit infanticide showed some key differences. They were more likely to be first-time parents and be employed. They often had prior involvement with CPS, usually for concerns about abuse and neglect. They had higher rates of personality disorders like borderline personality disorder. They were more likely to deny or attempt to conceal the act. So you can kind of see this pattern that mothers with psychosis in this study tended to fall more into the altruistic filicide category. They believed they were doing the right thing. They confessed their actions, whereas those without psychosis tended to fall more into the fatal maltreatment category and tended to conceal their acts. Now I want to shift gears to neonaticide, which is a distinct subtype of filicide, and it's usually not driven by psychosis, but rather pregnancy denial or concealment. So we'll take a look at the characteristics of neonaticide perpetrators, the prevalence and natural history of pregnancy denial. We'll look at pregnancy concealment. All of these have very important forensic considerations. So let's start with the typical neonaticide perpetrator. They're most often young, single women from lower socioeconomic backgrounds. They're frequently still living with their parents. They often go through pregnancy without receiving any prenatal care. Delivery is typically unassisted, taking place in secret, usually at home. And neonaticide is frequently preceded by either denial or concealment, or both. And so that gives us a general sense of who they are, but let's take a little dive into the data that shows more recently what neonaticide perpetrators look like in the US. So Wilson and colleagues analyzed 81 cases of neonaticide between 2008 and 2017. And they found that most of the mothers were young, unmarried, non-Hispanic Black women with low levels of educational attainment. So you can see that there's a lot of psychosocial stressors here. 2/3 gave birth at home without medical assistance. 3/4 had denied or concealed their pregnancy, and over 1/3 had discarded the infant's remains in the trash. So let's dive into what pregnancy denial is. So it refers to when a woman is either unaware that she's pregnant or is in denial of the pregnancy beyond 20 weeks gestation, when most women are typically aware that they're pregnant. So in these cases of pregnancy denial, typically even close family members, friends, and even healthcare providers are unaware that the individual is pregnant. There are a few subtypes. So pervasive denial, also called unperceived pregnancy or cryptic pregnancy, occurs when the woman is entirely unaware that she's pregnant. So she misattributes physical signs. So for instance, she believes her growing abdomen is weight gain, fetal movements are GI discomfort, missed periods are just, irregular cycles, or if she does have some spotting, which is common during pregnancy, she interprets it as her cycle. She may believe that she's infertile. So for instance, there's been cases where people believe that they had PCOS and so that they couldn't become pregnant. The fetus often is a breech presentation, so she may not show as much as other women or as much as you would expect. She might continue to use birth control and even see medical providers for unrelated concerns, with the pregnancy going undiagnosed, further reinforcing her denial. When she goes into labor, typically she will present to the hospital with other complaints like back pain or abdominal pain. Or alternatively, she will, labor will be complete surprise and she'll deliver unassisted at home, which can lead to significant blood loss. Pain oftentimes is very traumatizing. Some women report panic, confusion, dissociative symptoms during the delivery. And when the baby is born, there's no emotional bond to the baby. So it can be a dangerous combination, especially in young women who are very afraid. So it's important to recognize that if someone has pervasive denial and they're presented with direct evidence of the pregnancy, such as an ultrasound or a positive pregnancy test, that really two things can happen. Most commonly, the denial will lift. So she'll begin to emotionally prepare for her birth. Or alternatively, she may transition into affective denial. This is where she's consciously aware of the pregnancy on some level, but remains emotionally detached. So she avoids any mental or emotional preparation. She might refuse to speak about it or make plans and just ignore the reality of the pregnancy. So this is a form of really severe psychological denial. And because she's in this denial, the labor is often still a surprise. Now, the rarest subtype, this is very uncommon, is psychotic denial. It involves a fixed delusion that she's not pregnant. And this is even in the case of overwhelming evidence that she's pregnant. So this typically is occurring in the context of some primary psychotic disorder. Pregnancy denial is different from, pregnancy concealment is different from denial. So this is when a woman knows she's pregnant, but she's intentionally hiding it from others. And so sometimes there's even collusion in this case, like a partner is helping her to conceal it, or a mother is helping the woman conceal it from a father. It can follow affective denial, but oftentimes pregnancy concealment is much more in the woman's awareness. So when we're evaluating cases of neonaticide, we need to understand, was it preceded by denial or concealment? So courts have allowed expert testimony to explain how denial might affect a woman's mental state, especially when they're considering premeditation or diminished capacity to form intent. And so while insanity defenses based on pregnancy denial are usually unsuccessful, it can still be considered a mitigating factor. So we have to ask ourselves, was she truly unaware, or was this deliberate concealment? What evidence supports her awareness or unawareness, and did anyone else know? So now we're going to look at some studies which follow the natural course of pregnancy denial with populations that aren't necessarily involved in the legal system. And this can help us assess the credibility of a woman's claims if she didn't know she was pregnant. And this matters because jurors and judges are typically skeptical that someone is not aware of their pregnancy. So this data is from the Berlin study out of nearly 30,000 births, and it found that 1 in 454 involved pregnancy denial. So it's much more common than we previously believed. About a third didn't realize that they were pregnant until labor. So they had completely unexpected births. And the rest recognized it late in the third trimester. The median age was 27, with women ranging from adolescents all the way to their 40s. And most were in relationships and living with their partners, showing that this can really happen across a wide demographics. So more than half had been pregnant before. Most showed up at the hospital in labor. Only a few delivered alone at home. And notably, most kept custody of their babies. So denial of pregnancy doesn't automatically mean that someone is unfit to parent. And then Bonnet conducted a qualitative study in France between 1987 and 1989, and this involved in-depth interviews of 22 women who had anonymous childbirths and put the babies up for adoption. And they looked at personal history, pregnancy denial, emotional distress, and trauma. And so they found that most women realized they were pregnant very late, often between 5 and 9 months after the legal window for abortion. They didn't have any prenatal care. Labor often came as a surprise. Many had violent thoughts towards the fetus. Several had sought abortions but were denied. And there was a significant history of trauma present, especially sexual assault. So now that we've looked at the epidemiology and clinical features of filicide, especially postpartum psychosis and pregnancy denial, let's shift to how these cases can really play out in the legal system. So we're going to discuss a little bit about safe haven laws, infanticide laws, and criminal responsibility. So safe haven laws started in 1999 in the US, and they were intended to provide a legal alternative to child abandonment or neonaticide. So they now exist in all 50 states, and they give parents an anonymous way to relinquish an infant that's unharmed. So for example, in New Mexico, parents can surrender a baby who is less than 90 days old to a hospital, fire station, or law enforcement agency, and they won't be prosecuted for abandonment. And our CYFD, which is our version of CPS, assumes legal custody of the infant. So infanticide laws are statutes that reduce criminal liability of the mother who kills her infant, typically under the age of 12 months. So historically, infanticide laws reflected strong biases, especially around marital status. So for example, 19th century Germany, there were distinct legal consequences depending on whether the woman was married or unmarried. So unmarried women who killed their, quote, illegitimate child received 3 to 5 years imprisonment, whereas married women who killed their newborn were charged with first or second degree murder, commonly resulting in life imprisonment. In England, the Infanticide Acts of 1922 and 1938 created a legal distinction for women who killed their infants under the influence of postpartum mental disturbances. So these acts recognize that a woman might commit infanticide, quote, while the balance of her mind was disturbed due to not having fully recovered from childbirth or from the effects of lactation. And so these laws are still on the books in England and significantly reduce criminal culpability. Under this law, women who commit infanticide, they're often charged with manslaughter rather than murder, as long as it's clear that it occurred in the setting of postpartum mental illness. So contemporary infanticide laws are in place in about 20 countries across the world, including Canada, the UK, and Australia. So if you're practicing it in any of these countries, it is important to look at this specific legal standard for that country. In contrast, the US has no such infanticide-specific laws, meaning that these cases are prosecuted under general homicide statutes, which can result sometimes in more severe sentencing, even in cases where there was clear evidence of mental illness. So let's shift to look at filicide and the insanity defense. So in general, the insanity defense is rarely used in all of criminal cases, and it's even more rarely successful. It's raised in fewer than 1% of cases. But when it comes to maternal infanticide, especially cases involving postpartum psychosis, the success rate is a lot higher, anywhere from 15 to 27%, depending on the study. So that tells us that courts are more open to recognizing the role of postpartum mental illness in these situations. So this study looked at 34 filicide cases to see if the legal standard for insanity made a difference in case outcomes. So they compared states using McNaughton to those using the model penal code. And they looked at the outcomes such as not guilty by reason of insanity, guilty but mentally ill, and whether it resulted in a conviction. And so what did they find? That insanity defense was successful in nearly half the cases, regardless of the legal standard. So the specific legal standard didn't significantly influence the outcome. Conviction rates were also similar across both types of jurisdictions. And one of the important takeaways is that postpartum psychosis played a key role in successful insanity defenses. Courts were much more likely to accept this defense when there's clear evidence of psychosis. On the other hand, courts generally did not accept postpartum depression, PTSD, dissociative disorders, or personality disorders as grounds for an insanity defense. And this is important because in some cases of neonaticide preceded by pregnancy denial, experts have offered testimony that the defendant had a dissociative disorder, but this was often rejected for the basis of insanity. So even when psychosis is present, courts may interpret lucid and organized behavior as proof of sanity. So this brings up the point I made earlier that postpartum psychosis often fluctuates. Individuals can have moments of lucidity despite being severely impaired. And this nuance, I think, there's still a misunderstanding among courts about this particular detail. So while moms with postpartum psychosis are more likely to be found not guilty by reason of insanity, that's not usually the case in neonaticide. These women are often convicted, and sentencing is highly variable. So usually neonaticide cases are charged as manslaughter rather than the first or second degree murder, and the penalties do tend to be lighter, but it really can range from probation to even life imprisonment. And so this kind of variability shows why some experts think that infanticide laws could help create more consistent sentencing. All right, so I want to wrap up things, and there's a few key highlights that I want to that I hope that you can take away from this whenever you're consulting on these cases. So maternal filicide is a complex phenomenon shaped by mental illness, social stressors, and interpersonal dynamics. Courts often misunderstand peripartum mental health despite its relevance, in criminal responsibility and mitigation of filicide cases. One of the helpful tools for approaching these cases is the Resnick's 5 filicide typologies, which classify maternal motives. So there's altruistic, where the mother believes the death of the child is in her best interest, or is in the child's best interest. Acutely psychotic, which is one where there's no comprehensible motive. Unwanted child. Accidental, which is usually arising from fatal maltreatment that's unintended. And spousal revenge, where the child is killed to inflict pain on the partner. So that can provide a helpful framework for understanding motives and mental states. So child maltreatment and neglect are leading contributors to filicide with young children being the most vulnerable. So in these cases, when there's evidence of ongoing abuse or neglect, the court is less likely to find mitigating circumstances, and full culpability is often pursued. Postpartum psychosis is a key psychiatric risk factor for infanticide, and it's more likely than any other psychiatric condition to result in a successful insanity defense. Neonaticide differs from infanticide and is often linked to pregnancy denial and concealment. And in neonaticide cases, pregnancy denial especially when it's pervasive or effective denial, has been recognized by courts as a mitigating factor. And so these cases are often viewed as less premeditated, and charges are sometimes reduced to manslaughter, even if an insanity defense isn't pursued or isn't successful. Legal responses to maternal filicide vary internationally. So while some countries have infanticide statutes that explicitly recognize the impact of perinatal mental illness and reduce penalties accordingly, no such provisions occur in the United States, which leads to variability in how these cases are prosecuted and sentenced. So sentencing outcomes vary significantly. Neonaticide offenders generally receive lighter sentences than those convicted of infanticide or broader filicide, but it really can still range quite widely from probation to life imprisonment. And safe haven laws exist across the US to help prevent neonaticide by allowing anonymous surrender of infants, typically within the first few days or months of life. Okay, so that's my presentation, and I'd be happy to take any questions.
Thank you so much, Megan, Dr. Shed, for that overview on an often overlooked and really untapped, unknown topic for a lot of people in the forensic mental health field, as a number of questions here that are already here have suggested. There's a plethora of questions here already, but of course, if you have any other questions for Dr. Shed, feel free to enter those in the chat box. We'll do whatever we can for these for the moment. In the meantime, there's the QR code up there for the APA Continuing Education Survey. The link for it in the chat box will be posted later on. But in the meantime, we'll go ahead and run through a couple of these questions. I saw one question here asking more about the concept, the timeline of postpartum psychosis. Somebody asking, can depression or psychosis still be considered postpartum if the child is over 1 year old, even if the symptoms first started in the 4 weeks after birth? They gave an example of somebody that developed postpartum depression, but psychotic symptoms were not determined to have started until the child was about 15 months old. Psychosis-related filicide with attempted suicide occurred around 18 months old, and that a psychiatrist eventually concluded postpartum depression with psychotic features. Just thoughts on this timeline.
Yeah, that is a great question. So I would say that it depends on when the symptoms start. So if the episode of depression started in the postpartum, that would be considered, postpartum depression. Now, in the DSM, the timeline is a little bit different. It doesn't reflect the kind of wide range of postpartum symptoms that can occur, but I would still argue that this example is postpartum depression, even if it extends beyond that 1 year mark, because it's kind of arbitrary. I mean, we see women who are still lactating beyond 1 year and sometimes have worsening symptoms or emergence of depression with weaning. So I would look at whether they're lactating or not, or whether they recently weaned. But it's really helpful, I think, to explain to the courts that the onset of symptoms occurred during the postpartum period.
We've had a couple of questions when you discussed maternal filicide broadly. I think some people were thinking of fairly recent legislation and Supreme Court changes and all that related particularly to abortion. So one person asked, do you anticipate there being an uptick in maternal filicide with the overturning of Roe versus Wade and the rollback of abortion protections?
Yeah, that is a really great question. That's a great question. I do anticipate that's going to occur. And that's because it's actually been looked at in the literature. So with Resnick's original study, he was looking at cases in the pre-Roe era. And so he even speculated that liberal abortion laws would help reduce cases of neonaticide. But it doesn't rule them out completely, because oftentimes with if you have very extreme pregnancy denial, you have no idea you're pregnant until the moment of labor. And so I think there also needs to be more widespread understanding of safe haven laws as an alternative if you're in the position where you're having an unassisted, unexpected delivery.
Related to those Resnick typologies that you referenced there, somebody also asked, are there data suggesting a higher incidence of any of the Resnick typologies in states with stricter abortion restrictions?
I think it's an interesting question. I'm not aware of any specific data looking at that, but it would be something I think is worth exploring.
Some people asked about underpinnings, and one question here, some people asked about how much sleep deprivation can increase risk for postpartum psychosis. Somebody asked a broader question of how much of these factors, sleep deprivation, changes in stress level, and general hormonal medical changes that happen postpartum, like what kinds of, how do these factors contribute?
Yeah, so that's a wonderful question. I think that sleep deprivation is probably a major insult that at least I see it in my clinical practice, and I think it's fair to say it's reflected in the literature that sleep deprivation is a major contributor to postpartum depression and to the onset of postpartum psychosis. And I think that hormonal fluctuations are often there's some theory that the hormonal fluctuations play a major role, and we do see some women who only have episodes of depression or episodes of psychosis in the postpartum, and I think that there's probably a stronger biological contribution in those specific women.
Is there research that speaks to the role of substance use disorders or substance use in filicide?
Yeah, so those are associated with the substance use disorders are associated with filicides that occur as a result of fatal maltreatment, child abuse. So that's very common. It's often looking at epidemiologically at the data, it's often associated with postpartum psychosis as well. But then you have other, facts to contend with in court. So is it a substance-induced psychosis? So I think it is associated, but it's not always there. And in most cases where, an insanity defense is successful, it's not really confounded by substance use because I think courts are very skeptical of that. But from a clinical standpoint, we do see a connection. And I see it in my clinical practice a lot, working with, high-risk women with psychosis and with substance use disorders.
In your clinical experience there, somebody asked, how, as a mental health professional, how do you address the different types of pregnancy denial that you referenced if someone seems to be experiencing those?
Yeah, the major thing is sometimes these women don't really present to mental health professionals. They really present to their primary care physicians or emergency departments. So I think there needs to be more awareness among those professionals about making sure that they're assessing reproductive age women for pregnancy, even if they're on birth control, even if they, think that they're infertile or have PCOS, if there's any abdominal complaints or complaints, urinary tract infections, any complaints like that, we really need to be doing more routine screening of pregnancy so that we can make these women aware that they're pregnant. Because if you make them aware, then they have more time to prepare for birth and labor. So there's some literature that show, the Berlin study that was in Germany, and that was actually conducted by OBs who were really on top of this phenomenon, and they referred everybody to a psychiatrist or to a mental health professional. So I would say if you if you have someone who presents to an OB in labor and they weren't, they had no prenatal care, they really do need some sort of follow up with a mental health professional to kind of understand the situation and prevent it from happening, because there have been cases where women have had multiple pregnancy denials. They've been unaware that they were pregnant during subsequent pregnancies.
And do hospitals typically provide any psychoeducation on this topic, particularly to new mothers?
No, I don't see it happening here at UNM as much. I think it just really depends on how well integrated OBs are with like psych services and with social work services, and if the mental health professionals at the institution are aware of this phenomenon. I think that there's just in general a lack of understanding of maternal mental health issues and how that might intersect with mental health.
What are some particularly common mental health diagnoses, particularly in spousal revenge filicide that you referenced?
So those are more, so those in Resnick's typologies, those tended to be more men. Women did it as well, but there usually wasn't associated with mental illness. Things like personality disorders were more common, or just the circumstances were reflected significant marital conflict, divorce. So the circumstances around those seemed more important than any connection to mental illness.
Gotcha. And related to that, somebody did ask with the preface, great presentation, wondering if you could speak to any other data perhaps on male perpetrators of infanticide.
Well, we do know, so overall, so historically, women were more commonly the perpetrators of filicide broadly. That has changed over time, and now women and men are about equal in terms of how common they commit filicide, which I think is interesting because, for one, we know that male homicide offenders are disproportionately men are disproportionately male homicide offenders, and women have very low rates of homicide. But when women do kill, they tend to kill their children, and so because I focus mostly on women, I don't have a ton of knowledge about male perpetrators, apart from kind of how frequently it occurs.
Thank you for that. A couple of people at the end here all asked a similar question about this difference between denial and concealment, and any considerations in terms of how do you assess this? Are there assessment strategies for distinguishing denial from concealment?
Well, one big thing is if someone else knows about the pregnancy, that's a big sign that it's concealment rather than denial. Usually in pervasive denial, where the pregnancy is unperceived until labor, or in effective denial, where usually they become aware at some point, but they really just ignore. There's severe psychological denial there, so they don't even prepare for labor. Usually they don't tell anybody, and no one around them is aware that they're pregnant. And they might not have the typical signs of pregnancy, and it's difficult to kind of parse out, is it because they, what's the cause and effect there? Were they not showing as much, and so they didn't become aware of the pregnancy? Or is there something in the psychology of emotional preparation for birth and labor that causes your body to have more of the physiological changes? So that's a big question. So so looking for signs of if other people knew. If the woman is saying that she was in denial and was unaware, then look for signs that she was unaware. Was she taking birth control? Was she taking weight loss medication? Because she's like, I thought I was gaining weight. Was she exercising frequently? was she kind of acting in a way that suggested she didn't understand she was pregnant? Did she go to doctors and for complaints related to back pain or abdominal pain, and they didn't do a pregnancy test? So she kind of, it reinforced her idea that there's not a fetus inside of me. So I would look for those elements to help you understand if she was unaware.
We have reached the top of the hour. So Dr. Shed, thank you so much for sharing all of this information. The reception here has been incredible, as you see by the sheer number of comments and questions that continue to roll in, although we are unfortunately out of time there. And of course, thank you for your direct contributions here in New Mexico and at UNM in this area. I know it's been a welcome addition. We're happy to have you here, and thank you for sharing with the Law and Mental Health audience.
Thank you.
And that wraps up this week's Law and Mental Health series. Next week, we have Dr. Emmy Wood, who will be discussing unique considerations for competency evaluations for those with intellectual disabilities. So we hope to see you then for another great discussion of issues in behavioral health and the law. Until next time, take care.